Thanks, Anne-Marie, and thanks to Ovarian Cancer Australia for hosting this forum, as well as all the other educational forums that are held throughout the year, both online and in person. And of course, thank you to everyone who made it today to today's forum. So what I've been asked to cover is touch on research and clinical trials in ovarian cancer. So I'm going to touch on some fairly technical aspects of some of these trials, but really just leaving it as a backdrop to talk about what it really means in advances in ovarian cancer. And the outline is to talk about clinical trial design in general, the two biggest advances in recent years in ovarian cancer, immunotherapy and targeted therapies, of the ongoing efforts as well as future directions. So clinical trials can be divided into four sort of categories, and there is now more and more overlap between these different phases of trials. So an early phase trial or phase 1 trial is when a drug is tried for the first time in humans, and that's usually a very small trial. It lasts only several months, and the purpose is to identify the correct dose that we should be taking into larger trials. And then the next phase is when we expand the numbers of it, probably treating a group of individuals with the same condition, with the same cancer, and that gives us an indication of side effect in a larger group of patients, but also giving some preliminary indication of activity of these drugs. And then the larger trials are the phase 3 trials, which are usually national or international, and they often will compare or randomize patients to one intervention or the standard existing intervention, and they're what leads to ultimate registration or availability of these drugs in routine practice. And sometimes after drugs become available, there's some more research, which is phase 4 sort of trials that looks at real-world evidence or additional data to support what came from earlier trials. Because I'm showing a few of these, a survival curve is essentially a graph or a line graph that captures what is happening. Sometimes it's survival, so whether a patient is still alive or not, but also whether they are progressing or not. So it can either be indication of relapse or indication of dying from cancer. So you start at 1.0, which is 100%, and then this is an older indication of chemotherapy that doesn't work in melanoma from 20, 30 years ago. So this is a very, very ineffective treatment where not much is happening, and really this is the natural course of the illness. And as time passes along the bottom part of the graph, then less people are remaining alive. So the gap between the two curves is indicating whether treatment is actually effective or not, making a difference or not. So I'll start with immunotherapy, and by way of background, immunotherapy or understanding the importance of the immune system in cancer has been around for a very long time, 150 years. And that was when we recognized that there are immune cells, inflammatory cells, infiltrating cancer. But it took some time before that translated into treatment. But only probably a decade after that was the first immune therapy used in cancer, used in sarcoma, or cancer of the soft tissue and bones. And that's when they injected actually bacterial toxins around the tumor, which attracted a lot of immune cells to try and get rid of it, and showed significant responses. And that's in 1885. Fast forward another 70, 80 years, and an understanding of the immune system and how the immune system deals with cancer evolved, and the modern understanding of how a cancer interacts with the immune system. It can be described in one of three states: either that the immune system is able to eliminate, is identified all the cancer cells, and most of them, gets rid of them, and we are in a state of elimination. There's no evidence of disease, there's no progression of disease. Or the opposite end of the spectrum, which is escape. So the tumor cells are multiplying, the immune cells are trying to catch them, but they can't, and they continue to grow. So any progressing cancer is in a state of escape from the immune system. And then in between, where there can be a remission or cancer that's still present, but kept in check, not growing, not shrinking by the presence of these immune cells that specifically recognize those cancer cells. And cancer immunotherapy is probably one of the biggest advances in recent years, if not in 50 years. It is most prominent in other cancers, melanoma, lung cancer, bladder cancer, and renal cell cancer. It has not yet made major inroads into ovarian cancer, but there is a rapid emergence of new data to support its role in this setting. And we'll touch on some of these next. So essentially, that equilibrium and escape comes from a large number of signals, interactions between the tumor and the immune system. And these signals are designed to keep us, when we are in a healthy state, to keep our immune system stable, on standby, and ready to attack should we get a virus or an illness or a cancer. And these positive and negative regulators, all these different immune checkpoints, are there to be ready to either upregulate or slow down an immune response. And essentially, we've identified drugs that target some of these specific checkpoints. So when a cancer is dampening or reducing the response of the immune system against it, these drugs can reinvigorate and reactivate the immune system to do its job more effectively. So the drug is not specifically targeting the cancer in this case. It is targeting the immune system, reactivating it, or removing the barriers to its activation, and then the immune system is probably the best drug that we have against really any cancer, once we get that state changed from escape to equilibrium or elimination. And in ovarian cancer, we've known for a very long time that immune cells are important. So when a woman has initial surgery and to remove the ovarian cancer, they've looked at that tumor tissue and looked at whether it had a lot of immune cells present within it or not, and then classified these tumors to either tumors that have lots of immune cells compared to those that don't have a lot of immune cells. And looking at the survival curves again, those that had a lot of immune cells, with T cells, did extremely better than, much better than those that didn't. So survival was, going out 10 years plus, more than 50% of women were alive, compared to much lower when there was no immune activation. So we knew that there was a role for a long time. Just how do we modify the immune system to enhance that role is what we're working on at present. And this is probably the first trial that looked at immunotherapy in ovarian cancer, and this is now going back about 4 or 5 years. It's a small trial. This was a phase 1 trial, so it was only 20 patients, I think. And the figure here is showing 0, so there's no growth in tumor, and this is an increase in percentage, and this is a decrease in percentage. So there was only a small number for women that had either a reduction or stabilization of disease, but the important thing here is that it lasted for quite a long time. For more than a year, after just a single dose of that immunotherapy, there was still no evidence of tumor progression. And that means that the immune system was doing the job that long after having one dose of treatment. And this is not a new diagnosis. These are women that have had several recurrences of ovarian cancer in the past. So it's quite a difficult patient population. And this is just a summary as of probably 3 months ago of all the trials so far in recurrent ovarian cancer that looked at immunotherapy. And the number of patients is there, so all fairly small trials. Some of them are phase 2 trials. And jumping to the results, in the end, you can see that the response, which is ORR, has been quite modest. So it only worked in about 10, 15, maybe 20% of women to start with in these early trials. But things are improving in the later trials, the bottom 2, where instead of using one drug, there was a combination of either 2 different immunotherapies or combining immunotherapy with chemotherapy. That chance of benefit increased to 30 to 50%, which is quite a dramatic improvement. But these are still early days of these trials, and there's still larger trials that need to be designed and followed through. So this is just really an example of that second last trial, which is essentially recurrent ovarian cancer, and then like with other phase 2 trials, or some phase 2 trials where you can still compare 2 groups, they compared single drug to 2 immunotherapy drugs, followed by a single drug as maintenance treatment. And this is again recurrent ovarian cancer. And the response rate in those that had one drug only was 12%, whereas those that had 2 drugs was up to 33%. So again, promising numbers
relative to the early trials that only had that 10-15% chance. It does sound like a small number, but the important thing is with immune therapy, when it does work, it can work very well because these immune cells that are created can last much longer than the potentially shorter-lived effect of conventional treatment like chemo. And now we move these trials to new diagnosis, so early or initial diagnosis of ovarian cancer, and there's now a number of trials that are ongoing. 2 or 3 of these have been completed and are waiting for results, and the rest are either in early recruitment or halfway through. So these is now a large trial, so going up to 1,000 plus patients, and they all compare the conventional 6 cycles of chemotherapy to 6 cycles of chemotherapy plus immunotherapy at first diagnosis. So this is sort of what we are looking forward to in the next 2-3 years. And this is an example of these trials. This is one of the trials that we have here in Perth, and it's a national trial, again looking at combining standard chemotherapy with the 2 drugs for 6 cycles to the same 2 chemotherapy drugs plus 2 immunotherapy drugs, 3 cycles and then surgery and another 3 cycles, which is one of the approaches we use in some patients, and then looking at response within the tumor at the time of surgery, but also at the usual endpoints of delaying recurrence or avoiding recurrence. So that trial is about halfway recruited at the moment, so probably another year before we can see the outcome of this. And I won't go into detail. This is one of the other trials that's completed, which has chemotherapy with or without immunotherapy. So moving from immune therapy to targeted therapies. So a targeted therapy is a therapy that is going after a specific marker or flag or something that is present in the tumor, but is not present in normal tissue or other tissues in the body, or at least it is more prominent or more active within the tumor, and therefore if we can block that, and that particular target is driving the growth and survival of the cancer, then we can make fairly good reductions or good impact on reducing the risk of recurrence or in controlling the disease if it is recurred. And the first people to identify these sort of targets in cancer goes back again 40 years. They identified how to create antibodies, these molecules that can identify and track to a specific marker that's present on a cell only and not on other cells, or at least more active on these cells compared to other cells. And so the first targeted therapy probably in cancer came in the late 90s. It was in a lymphoma, in hematological cancers, and then we had Herceptin in breast cancer, which targets the HER2 receptor, and then more drugs came along in other leukemias and lung cancer and in breast cancer, but in ovarian cancer the first targeted drug was olaparib, which is a drug that targets a specific pathway which is involved in repairing damage to DNA, and we'll go to that in a second. This is when we first identified the BRCA genes, or BRCA1 and 2 genes, back in 1990 and 1994. These 2 genes were linked to hereditary breast and ovarian cancer syndromes, and hence the acronym BRCA is Breast Cancer Association Gene. And they're involved in this pathway, which is complex. We don't need to go through that in detail, but essentially all our cells undergo DNA damage every day, some more than others. So ultraviolet light can cause thousands of injuries to DNA per cell per day. Smoking can cause hundreds of thousands throughout our lifetime. And constantly we're trying to repair damage to that DNA, which is present in all cells. And there are several mechanisms, several ways of repairing the breaks to DNA, and the DNA has 2 sort of strands. You can either have one broken or both broken, and one of the ways of repairing double strand breaks, which is this bit, is a group of genes that are involved in using the normal copy of the DNA to try and copy it as truly as possible and replicate it, and therefore repair the damage that has been made. And the genes, some of the genes that are involved in this repair pathway, the homologous repair pathway, are the BRCA genes, but also other proteins and enzymes and genes are also involved in this, including a protein called PARP. So essentially, a woman with ovarian cancer that is driven by the BRCA mutation or caused by the BRCA mutation has impaired ability within those tumor cells to repair those breaks, damage to DNA, and a targeted drug that targets the PARP protein gives an additional injury, additional damage to the ability to repair that DNA, and therefore magnifies that cell death. And those tumors become very, very responsive to these drugs, at least for much longer than chemotherapy alone can potentially be effective. And the first trials of PARP inhibitors in ovarian cancer, again, now we're really starting to see big gaps between the curves. This is recurrent disease, so this is again cancer that has already recurred after initial treatment, but is driven by a BRCA mutation. The trials were still run in women that didn't have the BRCA gene, and in this trial, really all women, irrespective of whether they had a BRCA mutation or not, still got the benefit from the drug, whereas those that had a BRCA mutation, 1 or 2, either hereditary or just present in the tumor itself, had even a greater benefit from having those PARP inhibitors, which are tablets, which are oral medication. And then another trial looked at comparing the olaparib or placebo, so just no treatment essentially, in women that specifically had the BRCA mutation, and again showed a significant improvement in delaying recurrence. So hazard ratio of 0.3 means a 70% improvement compared to placebo. So if the cancer was going to recur after 5.5 months, in those that didn't have anything, no treatment whatsoever, that increased to 19 months by being on that PARP inhibitor in tumors that are sensitive to it. But then we start learning a bit more that the BRCA is not the only genes that are involved in this repair pathway. So here we've got the BRCA1 and BRCA2, either hereditary or in the tumor, but we've discovered that there's a lot of other abnormalities, genetic abnormalities, that may also impair the ability of cells to repair DNA. And in these women, probably up to 50% of women with ovarian cancer, if not more, can potentially benefit from these tablets, irrespective of whether they have the BRCA gene or not. And this is the result in those without the BRCA mutation, so non-BRCA ovarian cancer. There was still an improvement, not as big as it was in those with the BRCA gene, but still, when you compare the quality of life of not being on chemotherapy for longer periods of time, that incremental improvement was still beneficial. Moving from the recurrent disease, we tried these same drugs in newly diagnosed ovarian cancer, and there's 4 trials, the first of which, the SOLO-1 trial, is now completed and presents new diagnosis of ovarian cancer, finished chemotherapy, and gone to either placebo or that PARP inhibitor, olaparib. And the next slide shows the significant improvement in this group treated with olaparib. At the moment, more than 50% of women have not recurred 3 or 4 years on from starting treatment, compared to those that received placebo. So that treatment is now approved widely in different jurisdictions around the world, and it's becoming available in Australia really today for women that have the BRCA gene, either in the tumor or in the tumor. So these are the approvals worldwide, really different settings. So PARP inhibitors, these drugs that target this pathway, work in BRCA mutations in the tumor, in the blood if it's hereditary, but also they work after chemotherapy, they work in other trials without receiving any chemotherapy at all. So there's different sort of nuances to which setting they're approved, but probably there is a role for these PARP inhibitors in probably an increasing proportion of women with ovarian cancer, and probably still mostly talking about the most common subgroup of ovarian cancer, the high-grade serous, a bit less so in some of the other subgroups, but certainly any ovarian cancer with a BRCA mutation, and many of those high-grade serous, even without the BRCA mutation, can potentially now benefit. So over the last 15 years, this is the pathway to development from when we first identified the BRCA mutation to the ability of PARP inhibitors in the recurrent setting initially, but now also in the new diagnosis of ovarian cancer. So toxicity, and this is just an abbreviated summary, really to point out the difference between these three approaches. So chemotherapy, we've covered the breadth of side effects with Sam earlier. Targeted therapies are unique. They target specific pathways, and therefore they may have specific side effects to different drugs. So sometimes it's skin rashes, sometimes a bit more diarrhea. They're quite different to chemotherapy, and overall better tolerated. But the side effects relate to the specific targets that they are affecting. Whereas immunotherapy is not immune suppressive, it is actually stimulating the immune system, and really the side effects all relate to too much immune stimulation affecting other cells or healthy cells by causing inflammation in those areas too. So what's next? Really fine-tuning some of the above, and also working on the better understanding of ovarian cancer. That ovarian cancer is different, every person is different, but also we're now learning to try and classify ovarian cancer to different molecular subtypes, genetic subtypes, 4 or 5 subtypes, and what drives each of these tumor types, designing trials. And Australia is probably leading the world in trying to design trials that target a specific subgroup. We're trying to be more personalized in developing treatments and trials for ovarian cancer. It's not one size fits all. Like 2/3 of the women in this room at least would have had exactly the same 2 drugs for exactly the same duration and exactly the same dose. We're trying to improve on that and try and identify, okay, what should each individual person receive. So immunotherapy, because it's so promising, we want to know why did it not work in that many people initially, and drilling down on the tumor, understanding all the different interactions with other elements within the tumor, whether it's blood supply, or whether it's oxygenation, or whether it's scar, fibrous tissue that prevents immune cells from penetrating. If we try and break down these barriers, then we can develop better regimens of combination immunotherapy. And combinations, like with the 2 trials that I pointed out, maybe one immunotherapy is not going to be enough. Maybe we need 2 immunotherapies that target more than one of these immune checkpoints, and maybe we need to combine it with chemotherapy or radiotherapy or other things. So I'm going to skip on that because that's sort of another trial in development, and go on to the probably last slide, which is what I was saying, trying to move from empirical medicine approach to trying to subgroup patients, for example, the BRCA or other classification, to then really trying to personalize it into more individual treatments. So there's been a lot of breakthroughs, especially in the last few years. There's a lot that we need to do to improve the outcomes of women that are affected by this condition, and hopefully we're going to see a lot more coming in the next few years, and it wouldn't be possible without the contribution of patients, their supporters and families. That's all I have. Some questions? Yeah, please, yeah. Jan?
A bit of an observation just through that and what I've obviously personally experienced. It seems that if you have, if you've got a BRCA gene or a mutation like that, that the immune therapy seems to work better. And given that the BRCA gene is probably only 15% in ovarian cancer, it seems like it's sort of only targeting small group benefits from it. Would that be correct?
So, I mean, you've kind of combined the 2 things. So you're saying that the BRCA carriers may get more benefit from immunotherapy?
Yeah.
So far, we have not yet entirely proven this, but we think that might be the case. But there's no big trial yet to show us that the subgroup with the BRCA mutation is better. And that's because when there's a lot of DNA damage with the BRCA mutation, there's more stimulation of the immune system, and perhaps the immune drugs will work better. But we still have not quite seen that yet. But we'll probably see more of that when these big trials are published. We'll see whether the BRCA subgroup has a benefit or not. In terms of the 15%, so about 16 to 18% have a BRCA mutation that is hereditary. Another 6 to 8% have a BRCA mutation just in the tumor. So now up to a quarter of women with high-grade serous ovarian cancer might have a BRCA mutation that may benefit from these drugs, if identified. And probably another 25% that may have another alteration that is BRCA-like, but not quite BRCA, that may also allow them to benefit from the PARP inhibitors rather than immunotherapy. So we are pushing that 15% up to maybe 50.
In your choosing people, what about women who have ovarian cancer but also have other autoimmune diseases? You know, are they excluded from immunotherapy because they've got those other conditions other than ovarian cancer?
So we're trying to improve on that. So the earlier immunotherapy trials pretty much excluded anything that was autoimmune for fear of exacerbating it and making it worse. Now we're starting to have all these except for this, except for this, except for this. So now we're excluding, you know, immune thyroiditis, psoriasis, immune disorders or autoimmune disorders from a long time ago that haven't needed treatment for more than 2 years. So we're trying to improve on that, but by and large, proper full-blown autoimmune disorders that need immune suppression are still not eligible for trial. When we see these patients after the trials are completed and the drugs are available, and we don't have a choice, and we know it's really, really effective for someone with melanoma, but they have rheumatoid arthritis, they have been used, and there are publications to show they're still safe, and they get a bit more side effects, but they actually get at least the same benefit as others. So the trials versus real world, there's a bit of a separation between these two. Back first.
Sorry, while I find that quite impressive, you've not touched at all on any new diagnostic measures to, in fact, find ovarian cancer in early stages rather than when it's much later, which is more important, I feel, than treatment if you know
possibly, unfortunately, possibly because we haven't. We don't have that yet. We have nothing yet that is proven to identify ovarian cancer early, but there are efforts looking at DNA in the blood, and I'm not sure Paul will touch on that or not, but Paul's been involved in some of that research as well. But the reason I didn't touch on it as well is because it comes before I sort of come in.
Yeah.
I only deal with women once they have been diagnosed with ovarian cancer, but you're absolutely right. The most beneficial thing if we can just prevent it, but there's been huge efforts worldwide, tens of thousands of women included in trials to try and test CA125, ultrasound, etc., to try and save lives by picking it up early, and they still have not yielded a proven screening test.
Could I just mention, it's actually my partner who has ovarian cancer, but when she was diagnosed, she was late stage 3. The very last test she had done was the CA125, and her number was something like 2,500. My older sister, when my partner was after surgery, I went fanatical and told every one of my friends, have this CA125 test done. My sister went and saw her doctor, and he refused to do it. All my friends, I had one friend who actually dogmatically made their doctor do the test, and it was fine. My sister, in fact, 12 months later was diagnosed with ovarian cancer, and her reading was 4,500. Why do so many GPs refuse to do any testing?
I think the act of refusal is probably the problem. More important is a meaningful, educating discussion and explanation of why it is they don't think it's a good idea. This is the trials that I'm talking about. That thousands and thousands of women that had CA125 compared to no CA125, and has been shown that it does not save lives. So for a number of reasons, perhaps because the cancer will develop in between tests, perhaps when the CA125 is elevated, it's already advanced. When symptoms develop, it's already advanced. This is why 2/3 of ovarian cancer is diagnosed at stage 3 or 4, because symptoms don't develop until there is more significant burden of disease. But so far, CA125 alone, we actually do know it will not lead to an early diagnosis on a population basis. So there may be a role in some of the later research to try and look at specific subgroups. So someone should be targeted by a combination of tests because they have a higher risk compared to others. Certainly, family history, BRCA carriers, it's a completely different story. And in that case, screening is sometimes not even effective. You go straight to prevention through risk reduction. But I think the problem that you're describing is that they did not maybe have a good enough discussion explanation of why they did not agree or not offer them to have the test. But I cannot remember a single patient that I've seen in the last 5 or 10 years that has had an early diagnosis because they were regularly doing symptom. That's at least my anecdotal experience.
So you're saying that you've got the genes in a woman's metabolism is one thing, and then the tumour is also, there's a different tumour for ovarian cancer, and there's genes for ovarian cancer. What decides whether or not you give somebody with PARPI inhibitor? Has it got the BRCA gene as compared to, as I say, the tumour itself is different and the genes are different? So
there's probably 3 settings where we know they'll likely benefit. Number 1 is hereditary, so the one where it's in all cells. Number 2 is when it's acquired during life and is present in the tumour predominantly only. And the third is there is no BRCA mutation, but the cancer was very responsive to platinum, so carboplatin or cisplatin, and it does recur, but recurred more than 6 months from the previous chemotherapy. So the longer the duration from previous chemotherapy, this is a subgroup that benefited from PARP inhibitors irrespective of their BRCA mutation. So sensitivity to chemotherapy is almost predicting sensitivity to PARP inhibitors, because they almost work on the same mechanism as well. The platinum is causing DNA damage, and PARP inhibitors are affecting the same part.
So Pauline's been on Avastin for quite some time now, and so does Avastin have also some significance in terms of PARP inhibitors?
No, there's a trial that will be presented at a conference in 10 days in Chicago that is looking at first-line treatment and comparing Avastin after chemotherapy to Avastin and olaparib and a PARP inhibitor. And therefore we'll see whether there's an additive effect from the two things. And there's also trials in recurrent disease that are comparing PARP inhibitor alone to Avastin and PARP inhibitor, or Avastin alone to the combination. So we're trying to work out a completely different mechanism. It works on vascular endothelial growth, so it works on blood vessel sort of formation alterations. So it's a different mechanism, the leakage of blood vessels, so it kind of contributes to formation of ascites and fluid. And it has also evidence in initial diagnosis and in recurrent disease. But the interaction between Avastin and immunotherapy, Avastin and olaparib, is part of all these ongoing trials.
With the BRCA mutation being in the tumour only, you've had that somatic test that states that. If you've been on Avastin over that period since then, would that affect, the innovate study? The innovate study?
Yeah.
Is that, have we done Avastin previously?
Well, Innovate is a project to look at tumor characteristics and try and predict, future treatments. So if there's a somatic, it also depends on the setting. If it's new diagnosis or recurrent disease. So are you talking about initial diagnosis or later?
Part of it. Initial diagnosis, but it hasn't been recurrent yet.
Yeah. So initial diagnosis, if someone has.
But you've got Avastin for long term.
Yeah. So that's a bit of a tricky situation, because if we discover a somatic mutation, a mutation in the tumor only, 6 months into being on Avastin after finishing chemotherapy, we don't really know what to do then. But if I have someone newly diagnosed now, during their 6 cycles, we try and get the registry and the tumor testing before the 6 cycles are finished, so we know what to do after 6 cycles. Either have a PARP inhibitor if there's a somatic or germline mutation, or go on to Avastin if they're eligible and there is no mutation. But not both. I would not use them both together. There's no evidence to use them both together. And there's maybe a little bit of evidence that might be a detriment to use them both together. So someone with a somatic mutation discovered when they're cancer-free in follow-up, then that knowledge should be kept in reserve should it be required in the future. Because then that same individual will still be eligible later on if there is a recurrence.
Do you think there's potential trials for immunotherapy for the woman who was initially diagnosed went for the frontline treatment, and now on my Avastin are about to finish it. They're probably cure that situation. I think they will be eligible at some stage for immunotherapy.
Absolutely. I mean, all the trials started in the recurrent setting. So there's, that first table had 12 different trials looking at recurrent ovarian cancer after the initial treatment, and it recurred. And it's just that the percentage of benefit was modest, that we're trying to improve that more by saying having recurrence, having immunotherapy plus Avastin is one of the trials that is in Australia at the moment. So not when you're cancer-free. If someone's cancer-free, then there's very little trials at that point to switch onto. It is just, but they would be available in the future. So I think because we don't know yet who's going to benefit from what, clinical trials is a very good way of having access to potentially beneficial treatments until they become proven. And I think most women with ovarian cancer should at least be able to be considered or think about the opportunity for clinical trials at some point. And immunotherapy, we know that earlier is probably better. So that's why they've moved from the recurrent setting to the first line setting, because the longer things go on, the more resistant, not just to chemotherapy, but also to the immune system that tumors have become. We know that from many of the other tumor types, but also a couple of the ovarian cancer trials showed that if the immunotherapy was used in the fourth recurrence, it wasn't as good as when it was used in the second recurrence. So again, a lot of the next wave of trials are trying to come in early at first recurrence and try and use the immunotherapy if it hasn't been used up front.
If you've had your cancer and your surgery and you've had your chemo and you're in that window where you're cancer-free at the moment, is there any treatment that you can have at the moment to stop getting that first recurrence? Or, where does that leave us? Is it just watch and see? So
it depends on the subject. So there are two available treatments if there's two criteria met. So if someone has a BRCA gene, then as soon as they finish chemotherapy, they can go on to the PARP inhibitor if that is available. And if they don't have the BRCA gene, tumor or blood, but the tumor is a higher stage, then they're eligible for Avastin, which some people have mentioned. In the absence of these two, there is no treatment that is proven to delay recurrence after initial treatment. So when we tested the Avastin in lower stage 1, 2, or early stage 3, there was no advantage of being on it. It just means you're going back and forth and not necessarily getting any gain.
So if the CA125 isn't a reliable indicator of the presence of ovarian cancer, what else are they looking for in the blood when I'm at stage now, I finish chemo, I'm going every 4 months to an oncologist who looks at my blood results?
The utility of CA125 is completely different in a healthy population compared to ovarian cancer survivors. So in screening lots of women that have no symptoms and no concern for ovarian cancer, it's not reliable. But in women that have had ovarian cancer, it's very reliable in follow-up. So it is the most sensitive test and probably goes up 2 to 3 months before anything appears on a scan or before symptoms develop. So it is very useful in that setting and helps us avoid doing scans. However, there's also an older trial that says doing the CA125 regularly can also have detrimental effects, effect on anxiety and earlier initiation of treatment where it may not be needed if there are no symptoms. So it is possible that CA125 can go up for 3 months and there's no symptoms and no treatment, and starting at the beginning or end of the 3 months makes no difference whatsoever, other than longer time on treatment and more anxiety waiting for the results of CA125 every time. So in some parts of the world, they actually offer not doing CA125 monitoring because we don't know whether we know that doesn't influence outcome if all you receive after that is chemotherapy. So the trial is a bit old, so it doesn't really incorporate the new drugs. We have Avastin, PARP inhibitors, immunotherapy trials, etc. So we're not necessarily doing that very much in Australia. We're often using CA125 because that single trial is probably not enough to recommend against completely in follow-up.
Is ovarian cancer, when Pauline was first diagnosed, ovarian cancer follow a set path through the body, and I think is it still classed as a separate cancer, or do you now consider it the same as other cancers in the body?
As with many other cancers, the label or the treatment or the decision making for a cancer is largely dependent on the originating cells, where they come from, whether it's ovary, fallopian tube, or peritoneum, which is a lining within the abdominal cavity. So wherever it goes, provided that it's not a coincidental new cancer, it's still called ovarian cancer or tubal ovarian cancer.
Right, it's still.
Yeah, because that's what it came from. That's what it's, if you do the genetic sequencing, it would look like what it did in the beginning, albeit with some alteration over time, but still different from, say, a lung cancer or a breast cancer, even if it is in the lung.
Okay.
I don't know if this is your area. I heard of a long-term trial for Ovarian that has recently ended. See how just how long it can stay on.
In what cancer?
Ovarian.
In ovarian cancer. Long term. So
I just wondered if the results from that.
the only longer term is really 1 versus 2 years. I mean, I haven't seen anything beyond 2 years. There's one of the big trials that went for 2 years, went for 1 year, and the differences were not that huge to recommend going longer than the 1 year. But I'm not aware of anything that goes beyond 2 years. But some people do go on to that 2nd year, especially in the US, because of one trial that showed potential advances from that.
Right.
Okay.
Thank you so very much for having us.